So I think today we have David's favorite chief complaint, and we are having a 40-year-old female with multiple joint pain.
Okay. Now I'm not sure about today. So last time you told me, you briefed me that it's a difficult case. I probably won't get it right, but today I do not have any heads up. I'm not sure what will be going on, if it's a difficult one or not. But let's see where this takes us. Okay, so we have 40 years old female with multiple joint pains. Okay, so I'm not going to discuss the kind of information I'm going to need, because I believe you are going to give it to me. But then uh, when I think of joint pain, so let me just say, if a complaint is very new, so for joint pain, yes, it's a common complaint, and therefore I have some differentials. But then if it would be something very new, I would need to think in terms of the different kinds of diseases or syndromes that can affect that can lead to that particular complaint. But when I think about joint pain, we already have a pointer here that it's multiple joint pains, and therefore it will be our interest to know. So the number of joints involved, because that one helps us to narrow down the differentials. Because when you think of joint pains, it could be infections, and so you talk of an infection like something. So, for example, something like infective arthritis. It could be reactive. It could be an autoimmune disease. So autoimmune diseases like or connective tissue diseases like SLE, like rheumatoid arthritis, uh, like inflammatory myopathies, they can present with joint pain. And then you have other things, deposition. So deposition diseases like gout, pseudo gout. So you are talking of urate deposition or calcium pyrophosphate or oxalate deposition. And then so when you hear joint pain, I think another thing that you need to think about is, are we dealing with arthritis, or is it periarthritis? Or you could be thinking, maybe I'm talking about arthritis, but it's not exactly arthritis. It could be periarthritis, because you have structures around the joint, bursa, tendons, ligaments. Um, yes, so it could be anything. But then the number of joints is helpful. So we are hearing it's multiple joint pains, but more information will help us know what we are dealing with. Because yes, we also have arthralgia, so you may not have disease in the joint. It could be a systemic disease presenting joint pains. So we know infections like malaria. You have a lot of viral infections that could present with arthralgias, not exactly arthritis, but arthralgias. They could also present with joint pains. So I think we need more information to narrow down, but it's helpful. A female of reproductive age presenting with multiple joint pains. I already have a bias, but that could not be the case. So more information.
Okay, that's a good starter. Let's go to the HPI. So the story goes back to like more than 10 years ago when she was in her mid 20s. And she reports that when she was in her mid 20s, she started to experience painful swelling of the right elbow joint, which was on and off, extremely tender. She couldn't use her limb. Later on, she noticed pain in the right knee, which was worse during weight bearing, and it was later followed by pain of the left knee. So knee pain was associated with swelling and inability to walk due to pain, and she also reports to have experienced painful swelling of the right ring finger previously. So the knee pain had been chronic and was being managed by intraarticular steroids, which made them better. Over the years, she reports to be in persistent tolerable pain, which was intervened by periods of severe pain with swelling. So 4 years ago, she started presenting with back pain. She reports that the upper back pain is more severe than the lower back pain, and pain is worse during the night. Back pain worsens with rest and improves with activity. She also has pain in the neck, central chest, gluteal regions, and hips. The back pain is associated with morning stiffness, which can take more than an hour to resolve. And previously, her pain was being manageable with NSAIDs, but as the years went on, the response is decreasing. So there is no pain of hands or feet. There is no issue of eye pain or eye reddening. There is no skin rash, no abdominal pain, no diarrhea, no PV discharge. There is no insomnia except when she can't sleep due to pain, and there is no depressive mood. She denies any family member with the similar presentation. She denies weight loss, fever, night sweats. That's HPI.
Uh, can I see the first slide of the HPI? So this is a 40 years old female now, presenting with multiple joint pains, but seems we have a long history. Started in her mid-20s, and the pain was involving a single joint initially. She started to experience painful swelling of the right elbow joint, on and off, and then pain on the right knee. Okay. And then pain of the left knee. Pain was associated with swelling, inability to walk due to pain. Okay. Okay. So, yes, we are dealing with multiple joint pains. The presentation seems to be chronic. So we are dealing with a reproductive age female who is presenting with a chronic history of joint pains. And the evolution of the symptoms. One thing I'm not sure, maybe I would need clarification, is when the pain moved to a new joint, was the previously involved joint, was it improving or still painful?
Still painful.
Still painful. So the joint pain was basically additive and not exactly migratory.
Mm-hmm.
Although it can be difficult to clarify these things, but then I translate that to be more additive rather than migratory. So migratory is you have pain in one joint and then it moves to the next one, the other one gets better. But additive is on top of what you already have, you get pain in a new joint. Okay, then can I see the next slide again? I'm trying to see there's a pattern here.
Okay.
So at this point, she has bilateral knee pain, right? What
Yes.
about the elbow pain? Is it also bilateral?
No, it remained on that right upper limb.
Okay. And then she started 4 years ago, she started presenting with back pain.
Mm-hmm.
The back pain is worse during the night, worsens with rest, improves with activity.
Mm-hmm.
Pain in the neck, central chest, gluteal regions, and hips. Now you see the next one. Morning stiffness, which lasts for about an hour, initially manageable with NSAIDs, but response decreasing. No pain of hands or feet. no symptoms of uveitis, no abdominal pain, no diarrhea, no PV discharge. Yeah, so see, Joseph's history here is very well synthesized. So I believe people can follow because we've had multiple grand round presentations about joint pains. So when he talks about diarrhea, PV discharge, he's trying to look if what we are dealing with is reactive arthritis. And eye pain or reddening, uveitis, which can accompany some forms of joint pain. And there is no family member with similar presentation, no constitutional symptoms, weight loss, fever, or night sweats. Was that the last slide, or is there another one?
Yes, this I think this is the last. Yeah, this is the last.
Okay, so what I am seeing here is yes, they say diseases don't read books, but I have to remind myself what you also like to say, that before you say diseases don't read books, just ask yourself how many books have you read. And so what I'm seeing here is I'm not sure if we can call it a polyarthritis yet, and if we can say it is symmetrical, but it's definitely there is some element of inflammation. So the back pain that we are hearing, that one we are sure it's inflammatory back pain. It's worse during the night, associated with morning stiffness, and then improves with activity. So those features are features of inflammatory back pain. So there is a likelihood, and yes, we also have other features. The joint pain, especially initially, it was associated with swelling, inability to use the limb. So huge likelihood that we are dealing with inflammatory arthritis. There is one thing that is not very clear or hasn't been established about the symmetry, and then the number of joints involved. Uh, so I'm not exactly sure if at this point we know bilaterally the knees are involved, the elbow is unilateral. At some point we had involvement of a ring finger. I think we didn't hear if it was symmetrical. So concluding on the number of joints involved, whether this is an oligoarthritis or a polyarthritis, that one I'm not yet sure. But at least we are dealing with inflammatory joint pain. So we are dealing with arthritis associated with inflammatory back pain. So that by itself doesn't help us come to a diagnosis, but I'm considering a number of things here. I mentioned before that you could be dealing with infections when you talk of joint pains, but again, for this particular patient, I would say infections are not very likely because many joints being involved, and then the duration of these symptoms. And of course, if you have infective arthritis, it's a huge likelihood that you'll present with systemic symptoms like fever. So infections are less likely here. Reactive arthritis is commonly a monoarthritis. It can also be an oligoarthritis, but commonly a monoarthritis. So likelihood that we are dealing with reactive arthritis is very low. Could we dealing with the crystal deposition disease? Again, crystal deposition diseases are not typically presenting with multiple joint pains. And then when you consider the age of the patient, so something like gout is not very likely, and we haven't heard about any risk factors, but a crystal deposition disease is less likely. So for this particular patient, I prioritize some diseases, especially the autoimmune diseases. But with the history of the inflammatory back pain and then the joints being involved, there's a number of differentials I think about, especially spondyloarthritis. So it could be a spondyloarthritis Rheumatoid arthritis, SLE. So rheumatoid arthritis, what is against it is the age of the patient. But again, we cannot rule it out just based on the age of the patient. SLE could be a likelihood, but then we haven't heard about other features, skin and other findings that could help us add more points to a diagnosis of SLE. But I would say SLE could be a possibility, but most likely I'm thinking about a spondyloarthritis. I think I'm committing very early today, but we see further history, physical exam, and investigations. They may help me refine, but I'm considering these pains to be inflammatory, and those are a few differentials that I have. Maybe I'll get more over time.
Okay, so we move on, and not much today. We have other system, no numbness, no paresthesia or limb weakness. Past medical, past surgical history is non-contributory, and family and social history. She's married. She has three healthy kids. She's a lifelong non-smoker, doesn't use alcohol, and no other illicit substances. That's it.
Okay, so just one comment: the patient doesn't have limb weakness, so arthritis. So when we talk of arthritis, a lot of diseases are involved. Lots of diseases. I also mentioned inflammatory myopathies. So dermatomyositis and polymyositis can also present with joint pains as one of the presentations or as part of an overlap syndrome. So we do not see limb weakness in this patient. Yeah, so although yes, there are some forms of inflammatory myopathies which do not present with weakness, they present with other symptoms, but then that reduces the likelihood of those ones. So other components of the history, I think they do not help me make much progress. She doesn't take alcohol. So yes, alcohol is believed to be, so among people with hyperuricemia, it can be a precipitant of acute gouty arthritis. This patient doesn't use alcohol. And then as told before, no family history of a similar presentation. So it doesn't exactly rule out many things, but I think the family social as well as the review of systems were helpful to rule out some things, but not making much progress. So I'm still at the same point.
Hmm. Yeah, I saw some new people join. Then maybe you can have a summary of what we are presenting.
Yeah, so we've been hearing a presentation of a 40 years old female who presented with multiple joint pains. Can you remind me for how long? Oh, there was no, in the chief complaint,
Yeah,
there was no duration. Was there duration?
yeah. There was no duration. They started.
There was no duration.
Yeah.
Yeah, so she's a 40 years old female who has been presenting with multiple joint pains for a number of years. So all these symptoms started about 20 years ago. So when she was in her mid 20s, the first presentation was elbow pain, then followed by right knee pain, jumped to the left knee, and she had pain in her ring finger, I think.
Mhm.
And the pains were initially manageable with NSAIDs, but they later on got worse, and they associated with back pain, which is worse during the night, worse at rest, improves with activity, associated with morning stiffness, which can last for more than an hour.
Yeah. Sure.
She doesn't have any constitutional symptoms, no fevers, no night sweats, no weight loss.
Mm.
She doesn't use alcohol or illicit drugs, no neurological symptoms, no limb weakness, no sensory symptoms. She doesn't use alcohol, no family history of similar presentation.
Yeah, that's a superb summary. So I think we proceed. and we move to the general exam. So we start with a patient entering your room, and she's walking hunched over. She's moaning and wincing in pain. She's alert and oriented times three. She's a febrile. She has no conjunctival pallor, no jaundice, no palpable lymph nodes, and no lower lymphedema. The vitals are within normal limits. Blood pressure of 124/3, pulse rate of 64, respiratory rate of 66, and temperature of 36. Is saturating normal at room air. Systemic exam, the MSS. So on the back exam, she has an extremely tender point in the mid T spine, and also she has tenderness in the central anterior chest. There is no tenderness or swelling of the feet, ankles, knees, hands, arms, shoulders, and neck. Neuro exam, the eye centers are normal, cranial nerves are normal, motor exam, sensory, and coordination are all normal. Proceeding into her abdomen, she has a normal contour, non-tender, no organomegaly, no palpable mass. Chest, normal contour, moves normally. Vesicular breast sounds, no creps or wheezes. Cardiovascular, regular rate in rhythm, symmetrical pulses. S1 and S2 are normal. There is no murmur. So before the patient leaves your room, she asks for some minutes to stretch, and she has difficulty when standing due to back pain and stiffness. But after she walks back and forth in the room for 2 to 3 minutes, she's completely fine and she walks normally without pain. That's the exam.
Can I see the general exam again? Um, Especially the vitals, I see all vitals are basically within. Is that the respiratory rate 66, or
Yeah, this should.
was it a type?
Yeah, that's a typo. This is should be 16.
Okay, so basically, all vitals were within normal limits.
Sure.
Okay, and then the positive findings were tenderness in the T spine.
Mm-hmm.
Yeah, tenderness in the T spine, and then tenderness in the central anterior chest. Uh, okay, yeah, so no tenderness in the appendicular skeleton, basically, right?
Yeah.
So no tenderness in the ankles, in the knees, in the hands, arms, shoulders, neck.
Mm-hmm.
So it's tenderness in the spine and tenderness. Okay. Hmm. And then all other systemic examination is basically normal.
Sure.
Okay. This case could be more difficult than it seems because, as I said earlier, I'm already biased. So what I see here is that tenderness has been picked in the exoskeleton and no tenderness in the appendicular skeleton. So it would be an instinct to say we are dealing with an axial spondyloarthritis. But again, other differentials are also worth considering. For example, rheumatoid arthritis can also present with the pains and tenderness in the exoskeleton itself. So, uh, and of course, rheumatoid arthritis is part of spondyloarthritis, but I would say most probably we are dealing with axial spondyloarthritis. Rheumatoid arthritis is a close differential there. I do not really have. Uh, I'm not, but with this tenderness, we have tenderness in the central anterior chest. So basically, my assumption is we're having tenderness in sternum. in the sternum and surrounding structures. So could I consider other differentials, I mean, apart from the spondyloarthritis that we are talking about? Could it be something else? Maybe, but I think my thinking is very narrow today, because I do not see any other pointers to that could lead me to think about other diagnoses apart from the ones that I've mentioned. So those ones are at the top of the list, although I'm open to being surprised by the possibility that this could be something else apart from what I'm thinking. So maybe if there are any wake-ups, let's hear them and see if I can change my mind.
Okay. So here are the labs. Y count 2.9, slightly reduced. Neutrophils also reduced 1.18. HB 10.8. The machine's normal is 11 to 18. MCV 78 also reduced. Platelet 253 normal. Creatinine 84 normal. Urea 5 normal. ASTL, TLP all within normal limit. ESR, CRP also within normal limit. Rheumatoid factor was negative, and her urine analysis came back also normal.
Okay, that's all we have.
That's all we have for labs.
Okay. Um, so what's interesting here is my eye is on the inflammatory markers. ESR and CRP seem to be within normal limits. Now, does this tell us that we do not have inflammation going on? Uh, Maybe not 100%. And then we see some cytopenias there. You have leukopenia as well as anemia, but with the normal platelet count. So if I was to go back, I would say, if I take the tenderness that has been picked in the T-spine and the sternum, I would also like to throw out some other, I mean, to just throw in some other differentials. Apart from the inflammatory, apart from the spondyloarthritis I've been talking about, someone can have tenderness there because of an infection. So, for example, it could be a discitis, osteomyelitis of the bone, but then given the presentation that we've seen for a long time and the associated symptoms that we had, it's more likely we are dealing with a spondyloarthritis than those other differentials that I've mentioned. And then we have some other things that can present with bone pains. This patient has been presenting with joint pains, not specifically bone pains. So, and again, of course, the age at this point, 40, maybe is just uh, at the borderline when you talk about an increased risk of things like multiple myeloma. But then we didn't hear a history of bone pains. But then on examination, she has bone tenderness. Oh, yeah. So basically, the tenderness that we hear in the anterior chest could either be tenderness in the sternum or could be at the joints, so the costochondral junctions. So something like multiple myeloma, less likely because we did not hear about symptomatic bone pain, and then even the labs are not supportive of it. So the cytopenias could be because of the spondyloarthritis that we are talking about. Something like SLE, I do not see us having enough criteria to make a diagnosis of SLE, because we've heard about the joint pains, I haven't memorized the entire table, but I know we need at least 10 points. So the joints by themselves, I'm not sure if they can add up to 10 in addition to ANA if it's tested as an entry criterion. So SLE by itself, we see some cytopenias here, but we haven't heard about other presentations that could help us come to that diagnosis, but I may consider it, SLE. And then a negative rheumatoid factor. Yes, rheumatoid factor is very sensitive for rheumatoid arthritis. I think the sensitivity is over 80%. But that means we can have people who are seronegative. You have seronegative rheumatoid arthritis. So that by itself doesn't make me throw out a differential rheumatoid arthritis, but I'm more concerned about an axial spondyloarthritis. Although we have negative inflammatory markers, but I'll just need to review and see how often we can have an inflammatory arthritis, inflammatory back pain with normal markers of inflammation. I believe it's possible, but then in order to be sure, I would need to review that. Do we have anything else?
Sure, we do. So, are you ordering imaging? Oh, you just go on with making a diagnosis.
Well, so when we talk of spondyloarthritis, I think the imaging that will be more helpful is pelvic imaging, because we are interested to see the sacroiliitis. I think that that is the most sensitive one. It can help us. So if this patient has sacroiliitis and we heard that she has a history of hip pain, so there is a likelihood that there is sacroiliitis, and that can help us increase the confidence in what we are dealing with.
Okay. So we ordered the T spine first because of the tenderness that she had, and it was reported in normal by the radiologist. And from my eyes, I don't know about yours, but I also saw they were normal. And then we ordered the pelvic X-ray. Also, radiologists reported they are normal. There is no sacroiliitis. To you, David.
Okay, that's it.
That's it for the imaging.
Angle or not?
Yes, David.
Okay. So basically, for sacroiliitis, what you see, I think one of the earliest signs is, yes, Joseph.
Yeah, I think we katika kidogo. I can hear you.
Okay. Yeah. So I was saying the pelvic X-ray. I'm not sure. I think I'll have to trust the radiologist. But then uh, I see the left and the right are not exactly similar. They are not exactly similar. So on one side, so on my left side and everyone's left side, I believe uh, the joint space is not very clear. The joint space is not very clear now, whether that is due to rotation or anything else, but that is suspicious for me. But then he went to school for 3 years just doing images, so yeah, he's probably right. There is no sacroiliitis, but then to me, on my left side, I think that is a little suspicious. A reduction in joint space, and then it is shinier. So it could be that there are some features of sacroiliitis. Where do we go next?
If we assume he was right, there is no sacroiliitis. How do you move around?
Okay. So sacroiliitis itself, I do not think that absence of sacroiliitis can rule out spondyloarthritis. So uh, there is imaging, and then there are molecular studies. I'm not sure if I can say molecular studies. So HLA, is that B27 or is it DRR? It's DRR how much? I think I have to be reminded that one.
B27.
Uh, yes,
B27.
B27. Yes, so uh, that is another criterion that can help you in arriving at the diagnosis. So if there is a possibility of doing that, because with imaging, yes, you see sacroiliitis, it increases your confidence. But then if you can do that one, HLA-B27, it also helps you make progress. So I think that would be my way around. But then I'm not sure if those ones are available in our setting.
Okay. I think everyone understands when I say this is David's favorite chief complaint. Okay, so we move on, and we order. Oh, is there any more labs other than the B27 that you're thinking that you can order at this moment to rule out or rule in some differential diagnosis that you're thinking?
So, well, that would just be fishing for differential. So, for example, I mean, I can wait to be surprised, but then the likelihood that we are dealing with something like hyperuricemia is okay. Wait, yes, I mean, I cannot completely rule not completely to start presenting with gouty arthritis. So you presented that initially she started presenting with, was that right elbow pain?
Yes, right elbow pain.
Right elbow pain, was it associated with swelling and redness?
Yes. No, she didn't
Okay.
say redness. She said swelling
Okay, so it was swelling.
and warm.
Okay. Yes, I mean, but that would be very far fetched. Although I should say that we can never say never. But commonly, hyperuricemia and gout. So gouty arthritis tends to involve the small joints, although it can also proceed and involve larger joints, and and of course lead to senior. That is a possibility. But then with the epidemiology of the patient, that one will be very far fetched. Although, and yes, we could do so. Other labs, I'd consider doing uric acid levels, although we know that there are many people who have hyperuricemia, but the hyperuricemia is asymptomatic, and therefore we could do uric acid levels and find them elevated and treat the patient for hyperuricemia, but then probably we are wrong with the diagnosis. So apart from HLA-B27, uric acid levels, I can quickly think of another lab that I would need to order. So I think mostly I would just struggle to see if I can confirm a diagnosis of spondyloarthritis. But these other possibilities, and yes, other labs, uh, an autoimmune profile. So an ANA profile, although as I said earlier, are not very likely. So for something like SLE, we see the joint pains, we do not have, and we see some cytopenias in the full blood picture. So if we put all of these, we could see how many points she scored. But then, yes, maybe another profile. And if rheumatoid factor is negative, I'm not sure how many times. and TCCP will be positive. So I'll go for uric acid levels, HLA-B27, and ANA profile.
Okay, we decided to order anti-CCP, which came back negative. Does it increase or decrease your differential diagnosis?
Yeah, so first of all, the age of the patient, rheumatoid arthritis, unless, which is a topic I should read in detail about, juvenile rheumatoid arthritis. So if we are talking of rheumatoid arthritis proper, the peak incidence is a little older. This presentation is from 20 years of age. So right from the beginning, my suspicion of rheumatoid arthritis was very low. And then we have negative rheumatoid factor, which, as I said, the sensitivity is more than 80%. Maybe it can cross 90, but at least 80%. And then anti-CCP negative. So we are talking about a double negative here. And then even the presentation, the small joints do not seem to be very much involved in this patient. So the small joints of the hands as well as feet were not very much involved, apart from one joint that we had, the little finger. That was the ring finger.
Mhm.
And then we also do not see the typical symmetry that presents in patients with rheumatoid arthritis. So small joints not involved, we do not see typical symmetry, the age is against it, and then double negative. So rheumatoid arthritis is less likely.
Sure. All right. So, are you committing, David?
Right. Well, I'll just commit, and so the inflammatory back pain, the tenderness that we picked, yes, I would say this is an axial spondyloarthritis.
Yeah. So, for the benefit of people who are listening here, they see back pain almost every day. I think maybe more than 20% of patients they will see in clinic one day. Why are you calling this inflammatory back pain and not the usual back pain that should be treated with?
Okay. Yeah. So back pain, the reason for calling it inflammatory back pain. So you have back pain that is actually there is a number of characteristics. I think about six. So I would encourage everyone to go on Harrison's.
Sure.
Was yes, on Harrison's, I believe it's the chapter on the spondyloarthritis, if I remember correctly. There are these six characteristics that will qualify back pain to be called inflammatory back pain. So one of them is the pain is worse at night. It can wake the patient at night. So that is one. And then two, the pain is worse at rest and improves with activity. And then this pain is associated with morning stiffness. So those are some. I do not remember the others, but those are some of the features that made me call this inflammatory back pain.
Mhm.
Yes. So maybe we can go and review on Harrison's.
Sure. And when you're saying um, spondyloarthritis, you realize it's a group of diseases. Do you choose one and say this
Yeah.
patient has this one?
Okay. So yeah. So this one axial spondyloarthritis. Because yes, spondyloarthritis, I think even rheumatoid arthritis is part of it, and then we have others. Even psoriatic arthritis is one of the differentials in there. So this one is axial spondyloarthritis.
All right, David. So yeah, your thinking was like my thinking, and I think you got this one straightforward, right? But I think you must be confusing something. Rheumatoid arthritis is not part of spondyloarthritis, as far as I can tell in my readings. So yes, the presentation 4 years ago, as you're saying, it is an inflammatory back pain for the reasons that you said, and we'll learn in the learning points later. And it's typical for ankylosing spondylitis, which is, if the radiologist was right, is non-radiographic, and I believe he was right. But yes, there is something I didn't know when we was ordering the X-ray. When I went to read, it was said if you order the X-ray for this, tell them to do what is called a Ferguson view. They angle in some way the machine so that you can see clearly the sacroiliac joints. But again, you cannot have just on one side. I think maybe that David was a rotation. You have to see it on both sides. But even if it's negative, this is clinical diagnosis. You say just non-radiographic ankylosing spondylitis, which was the diagnosis in this patient. And the extremely tender point on the mid T-spine, that when you palpated, patient jumped up with pain. I thought it to be an enthesitis. Initially, as I was taught, I thought, first of all, enthesitis is a point where a ligament or a tendon attached to a bone, or sometimes a periarticular joint capsule attached to a bone. So it can occur anywhere, and the point on the back that we were touching, it was enthesitis, which a supraspinal ligament was attaching to a spinous process on that point. And so was the tenderness on the anterior chest between the joint between the costal bones and the costochondral joints. So the presentation more than a decade ago was supposed to be a peripheral ankylosing spondylitis. We'll later learn that this is a group of diseases which are related, as David was alluding to, B27 stuff. And the swollen tender right finger, David, was not a single joint. When I asked her, she showed me a whole joint. I asked her, was it like a sausage? She said, yes, it was like a sausage. So it was a dactylitis, a sausage finger. And here is the,
Joseph,
yeah. Yes, David. Hello? Can you hear me?
yes,
Aha, nilipotea kidogo. Hello?
Tunakupata daktari.
Okay, and you can see my slide.
Yes.
David anipata.
yes, the slide is seen.
Mm.
Can you repeat the point on the ring finger and then proceed from there?
Yeah, so it wasn't just a single interphalangeal joint on the ring finger. It was the whole finger. And I asked the patient, was it like a sausage? She said, yes, it was like a sausage. So I realized it was a dactylitis, a sausage-like finger. So here is the representation of a family of diseases called spondyloarthritis. So it's a group of different diseases which have very related characteristics. One of them being ankylosing spondylitis, which can be in two forms, either peripheral or axial. This patient, as you can see, she started years ago with a peripheral spondyloarthritis. There was no back pain back then. And then later, she morphed into another form, which is axial spondyloarthritis. And the axial one can be either radiographic, as David said, you can see sacroiliitis on X-ray, not on any other imaging. It's an X-ray. And then there are others like reactive arthritis, IBD-related arthritis, psoriatic arthritis, juvenile ankylosing spondylitis, and another one is called unclassified. There are symptoms, and you cannot classify into these categories. So some few learning points for you guys. So these spondyloarthritis family share some features, and them being axial joint inflammation, asymmetrical oligoarthritis. Remember how the patient presented back then. Dactylitis, these are sausage-like fingers. Enthesitis, the tenderness on the point where tendons connect to bones, and HLA-B27 positivity. So, like around more than 90% of patients with these spondyloarthritis are HLA-B27 positive, but there are many people in the population who are HLA-B27 positive and they don't have spondyloarthritis. So, it's significant, it's not known. And if we can test it, and it is positive, you increase your likelihood. But if it's negative, you don't say it is not spondyloarthritis. So these entities aren't necessarily discrete. They can overlap, as you can see in our patients. And then the peripheral spondyloarthritis, they usually later on evolve into another specific diagnosis. Like here, they started as a peripheral ankylosing spondylitis, and later on they morphed um, into axial non-radiographic spondyloarthritis. Some other teaching points, I have them on my notes. I think I can share it here. I usually take notes because it helps me. Let me see this one. Can you all see this?
Yes.
Yes.
Yeah. So at the top there, these are my notes, and at the top there is the classification I was talking about. I think the image I showed you previously explains it better. I'll move down here for ankylosing spondylitis, which is the topic of today. Then, yes, it's an inflammatory arthritis of the spine, which occur in people less than 45 years of age. The epidemiology is that 5% of people you'll be seeing, they'll coming to clinic, they have a low back pain. 5% of them will be having ankylosing spondylitis. So it's very crucial, as David was talking about inflammatory back pain, to recognize that, because if you don't, outcome is not going to be good. Okay. Also, there can be a genetic component in these diseases, and depending on what you're looking, the epidemiology can be, it's more common in men than female, but other studies show that the is equal in the two gender. So the presentation, yes, inflammatory back pain is the center of it, and yes, it occurs in age below 40. Nocturnal pain, pain at rest, it improves with activity. It is insidious, and there is morning stiffness. So this patient, when she's about when she's sitting and she's rising up, she has a lot of pain, and when she stretch a bit, she's normal. If you find her walking, you cannot believe that she's the one who can't even walk after just standing up. But if it gets advanced, patient can present with structural and postural abnormalities. They also have neck, buttock, hip pain, and also the peripheral manifestation can be present in 30% of patients, like in ankles, hips, knees, shoulders. Enthesitis, we have talked about, dactylitis, Schober's test, you can see on Google how it is done. I had no time to perform it. And another test is lateral spine flexion. So, yes, labs are non-specific. 50 to 70% have elevated ESR, CRP, and HLA-B27 is positive in 78% of patients. Imaging, sacroiliac, Yoda Ferguson, and I've talked about it. You'll see narrowing of sclerosis and other things. The diagnosis is clinical. There is no test that you can do and say it's ankylosing spondylitis. So, treatment, physiotherapy, and exercise of the patient, posture training, NSAIDs. But this patient, I sent her to physiotherapy. First of all, she was a cash patient. She could afford much. NSAIDs was starting to go down. So I realized the patient too will need biologics because there was no good response to these initial. But again, she biologics availability first of all, and then it's so expensive. The first line is etanercept. I couldn't find it anywhere. So good thing she's coming from Zanzibar. Healthcare is free there, though she says she'll go to continue the physiotherapy there. And if there is only peripheral arthritis, as initially, if you found her initially with no axial symptoms, NSAID, steroids, methotrexate will be sufficient. Yeah, David, you got this right, my brother.
Thank you very much.
I believe you do rheum round one day. Oh, am I mistaken?
Pardon?
I believe one day you're going to do rheumatology. Adult rheumatology.
I'm not I'm not exactly sure about that. I might remain a general physician forever.
Yeah, it's interesting to be a general physician, by the way. Yeah, do we have any insights, anything, questions? David is a super specialist here already.
Okay, karibuni madaktari. If there are any questions, any comments.
No comment, no reflection. Was it such an easy case? I think it was an easy case. Alex?
Yes, uh,
Alex.
that was a nice case and an interesting one, especially with the timing of the disease when it started. But also, we have to give credit to the patient herself too for keeping the records. It's very difficult. Something started in mid 20s, now she's around 40s. People that track that lady Joseph, where you reached me. But I'm interested. Why didn't we think? I mean, why did the lack of migratory presentation take us away completely from syphilitic arthritis and don't test it at all?
Yeah, you mean you should have considered syphilis.
Yeah, at least to be sure, because not all syphilitic arthritis could be migratory. Sometimes it might not be migratory and also has the similar presentation that improves with movement, but also night pain is there. So I think it was necessary to rule out that one. I don't know. How do you guys see that?
Uh, for me,
I mean,
I think maybe I'm having uh, uh, my knowledge on syphilis infections of the joints. I'm not well equipped on that. Uh, my schema of joint of arthritis, as far as I can consider infections, I don't know. Maybe I have to read on syphilis. Yeah, but it's a good thought. Maybe we should have considered, but I thought it tallies better with ankylosing spondylitis than any other thing I could think of in this patient. I don't know about David.
So, Alex, your question was that maybe Joseph should have thought about this being syphilis.
Mm,
I mean, just to rule out, not say because there are some findings that I know we are always pulled away with the migratory joint pain. But sometimes they might not be migratory, might be addictive like this one. So I was interested at least to rule out if by doing maybe the RIL to be sure not. It's not there. It's not typical, but you can't
Oh,
rule out it, especially in our settings where these sexual transmitted diseases they are somehow
so
prevalent.
yeah, so the presentation, uh, and so I believe you are talking about if it's syphilis or something different from reactive arthritis. So
Yes,
presentation of
sister,
syphilis in
sister,
the
sister.
yeah. So presentation of syphilis in a joint. Okay, syphilis in a joint. So I believe, as Joseph said, that would have been, now it's syphilis infecting the joint. Now I'm not exactly sure at what point is it as a primary infection or secondary syphilis, but the presentation in this particular patient, I think it was more in keeping with the spondyloarthritis, especially the inflammatory back pain. Now I do not remember reading about syphilis presenting in a way close to this, but maybe we would need to give that a check and see if it could also explain this one. That one I'm not sure.
Sure. Thank you, Alex.
Oh, you're welcome, Justin. And thanks, David, too, for the clarification.
Karibu. Do we have anyone else with any question, any comment, any insights that you would need to share? Yes, Shani Abbas, karibu.
Thank you so much. So I just wanted to add on. So like we said that the diagnosis is spondyloarthritis, and the way Dr. Masalu Pia, he said that most likely we are dealing with an axial type of ankylosing spondylitis. I know my rheumatology is old, semester 2, but I'll try to remember myself that there are two types. Like he was saying, there's the axial type and the peripheral type. And what the patient probably was presenting with initially when she had involvement of peripheral joints, then it was involving the peripheral ankylosing spondylitis. But what she's presenting currently is the axial one. So actually there's a criteria that has been set. As you can see that these spondyloarthritis nasema zinaingiliana in a way that there is part that is psoriatic arthritis, there's the axial and the peripheral ankylosing spondylitis, like the Venn diagram Dr. Masal was showing. So there is a criteria that is set by the International Society of Spondyloarthritis classification, and it divides how to diagnose if this is an axial spondyloarthritis or is it a peripheral spondyloarthritis. So I was trying to put in what Dr. Masalu was saying with the case. The patient fits very well with the axial spondyloarthritis. So you need back pain for more than 3 months. So the patient had that. And usually the axial spondyloarthritis, the usually presents in less than 45 years of age. So our patient, if I remember correctly, is 40. So those are the two entry criteria. And then what is the next thing is the radio imaging, which can either, you need to look for sacroiliitis, like Dr. David was saying. So you could have radiographic positive or non-radiographic. And we saw that our patient was mostly non-radiographic. So if the patient is non-radiographic, then you need two things. One, usually they use genetic susceptibility, which is the HLA-B27 positivity. So if you have that, then you need two more features of spondyloarthritis. So these include like inflammatory back pain, like we were saying that this patient has inflammatory back pain. And then we also thought of those sausage digits, maybe the tenderness on the costal region, maybe as enthesitis. So the patient had that. The sausage-shaped fingers, dactylitis. So those are already three. So you need two or more, plus the HLA positivity. So there are other more features of spondyloarthritis, including uveitis, psoriasis, inflammatory bowel disease, and family history as well. So those could also be other features. So if I take this patient as a whole, she fits under the International Society classification of spondyloarthritis. So that's a good thing. Just the second point, maybe my last point, it's not only genetic factors that play a role in the pathogenesis, which is the HLA-B27, like Dr. Masalu said, that you might be HLA-B27 positive, but you might not present with these features. They say only 6% of those who are positive usually present with the disease. And this also shows that sometimes there are other factors. So they're talking about environmental factors, for example. The environmental factors, they say that these patients, almost 60% of them have ileitis, like terminal ileum inflammation. And through that, they report that there are some bacterial pathogens that usually enter the bloodstream that also predispose to this spondyloarthritis. But they also talk about tissue factors, that the joints that are involved in this condition are usually high in fibrocartilage rich joints. So, like the ones in the ilium, the acetabulum, they're usually most affected, and that leads to sacroiliitis. But this also shows that they also have extra articular manifestation. Unlikely for a patient, she did not have, but the most common ones are they involve the anterior eye, so they cause uveitis in these patients. They could involve the aorta, causing aortitis, predisposing them to even coronary artery disease, and other involvement, including pulmonary involvement as well. And they also say that these sites, extraarticular sites, are also high in fibrocartilage as well, and thus they are also susceptible. So that's all. Thank you.
Thank you very much, Shani. You are your rheumatology is as fresh as yesterday. So yeah, you reminded me something. I said other practitioners, when they find an axial radiographic, a non-radiographic axial spondyloarthritis, they do an MRI, and if read well, it can show early signs of inflammation, but it is not part of the classification. Yeah, thank you very much, Shan. That's so insightful, so superb, as always.
Thank you.
Okay, do we have anyone else with anything, any comments, any questions, suggestions, any piece of shule that you'd like to share with us?
I think no, and we are past an hour mark, David. Maybe.
Okay, so thank you everyone for joining today. It's been an interesting case from Joseph. I think being joint pain, yes, it's a familiar complaint, and therefore was a bit disorganized. I was a bit disorganized, but I believe I have a few things to go and work on. I also believe that through the discussions that we've had here, everyone has a thing to go and cement on. So thank you everyone for joining. We hope to meet again next week and to keep learning. So, and thank you, Joseph, for presenting the case, for bringing these interesting cases to challenge our thinking and to make us learn more. So I'd like to wish everyone a good night and meet you next weekend.
Bye.